Thank you very much
Merci beaucoup.
for this great talk. Je peux avoir le micro, s'il vous plaît? Non. Est-ce qu'il y a des questions dans la salle? Donc,
Any questions for Eric Cohen or for Dr. Lipschulz? For the heart, kidney, either? Let me begin with a question. I have a question for both the speakers. In both your presentations regarding the pharmacological preventive strategies, kidney and heart damage, in fact, both speakers mentioned the DC inhibitors. Do you feel that DC inhibitors is a possibility of research, to prevent cardiac or renal damage, or both?
Are you talking about the dextrazoxane studies?
no, you presented the data on enalapril.
Yes.
And Eric Cohen, right before, presented some data on captopril.
Yep.
So Eric on the prevention of kidney damage, and you on the prevention, delay, you said it in conclusion, of heart damage. And the question is, do you think that this class of rather ancient drugs would deserve more in-depth clinical studies in terms of in prevention or protection?
So in children and in adults, ACE inhibitors, beta blockers, other anti-congestive therapies have been used in a number of settings. And during therapy, it looks in many of the studies, including some of our own, that you will see improved numbers in terms of improved heart function or preserved heart function, maybe reduced cardiac biomarkers of injury. There really are not studies that have looked long-term to see is there a sustained improvement. And the study that I showed was not a during therapy study. That was in people years later. And we tend to think that if you're going to intervene, it might be better during therapy. The problem is those are not mechanism specific therapies, and they're really more general. So although you get improvements in numbers, whether that really protects the heart against the type of targeted injury remains still completely unanswered, at least from a cardiac perspective.
Okay, thank you. Eric, do you want to comment?
La question, je crois, c'est
I think your question was concentrated on the ACE inhibitors, and to say that these are ancient drugs, some of us feel. Now, ACE inhibitors, I use them. I mean, I looked at them for radiation. And in laboratories, we have been able to prove that a nifrtanidic, as well as the pulmonary area, is also protected or even mitigated by these agents. By mitigation, I mean that the introduction of the agent after radiation, but prior to the damage really be seen. So this use can be useful in oncology because you've already done the RT or radiotherapy or chemotherapy, and then you introduce this agent. Now, at a clinical level, I showed my results to you. I showed you that so far the trends were fairly positive. However, the p-values didn't reach a critical level because there is a reduction in the number of patients below, in fact, the number that we'd have liked to follow. Now, quite obviously, that these various agents radiation as opposed to chemotherapy versus other agents that are used in oncology, it's quite obviously that this choice of treatment, mitigating treatment, or to reduce induced damage, it's quite obvious that we will need to pick or choose these different agents. I'm not saying that ACE inhibitors are a panacea, far from that. We need to pick the agent according to the model or the problem at stake. Lenalapril is apparently not efficacious in the long run in the models and problems that you just heard about. I assume that ACE inhibitors could be useful for radiotherapy from that point of view. I'm involved in a study which is trying to find an answer to this question, radiotherapy for lung cancer. Thank you. If there are no further questions.
Study that we showed using an ACE inhibitor, these have been around, since the mid-1980s. And when we started looking at the ACE inhibitors, we actually found that for childhood cancer patients receiving anthracycline, and also in cases where we looked at it with radiotherapy, what we found was there was, as I showed you, an improvement in ejection fraction preservation, and but it was because the diastolic blood pressure was reduced. And in doing that, it led to less stress on the heart and improved function. When we looked at serially, the biggest problem we see in children is this loss of heart muscle, the wall thickness going down, the mass going down. That was totally unaffected. So again, getting at the protection of the basic mechanism, there was no protection from that. But we did see that function was preserved, but because it lowered blood pressure was the main reason. So again, if we're looking at, is this going to have a long-term beneficial effect, that's where we've tried to target where the primary effects on the heart really are.
Okay. Thank you very much. Donc, s'il n'y a plus de questions.
If there are no further questions, let me just conclude by saying that we have. Do you have a? I was about to give you the floor, but go on. Yeah, but finish with what you have to say. I said that we were broaching this subject from the point of view of cancer and its impact on kidney and heart. And the other way around, we are seeing that there's a lot of data coming in and how to treat a cancer with people who already have existing renal problems and so on. So I'd like Joseph to comment on that. We talked about it between us, how to manage cancer in a patient and with aging population. So we're going to see this increasingly. They might already have a cardiac problem. So do we have any data? Are we beginning to see it? And what sort of problems are we going to see in practice? Well, I have a question before. I think there are quite a few drugs coming along now which help prevent the use of other cardiotoxic agents, anthracyclines to begin with. That's pretty clear. Thinking of breast cancer, there's still some other rare diseases where we do use anthracycline for sarcoma, but it's rare. But to react to what you said, I asked Mr. Lipschultz, I'd like to ask him, you talked about dextrazoxane, and we all know, in fact, you've contributed to several studies on it, and there's other work also that has been published, particularly for breast cancer. And a few years ago, there was a sort of warning or a sort of hesitation in the use of this drug. And this was based on rather preliminary data, which was evoking not a protective effect, but even a negative effect on the efficacy of anti-cancer therapy. So now there was, you showed us some great curves of survival in cancer in hematological acute leukemia in children. So we all withdrew from the use of this drug. Now today, do we continue on this assumption that there's a negative interaction with anti-cancer drugs? And secondly, sorry, I'm going on and on. You also published some work on troponin and biomarkers that might potentially be used to identify populations at risk, of toxicity. Are these things that we can still use in practice? Is there any point to it, or is it still just experimentation at that stage? Now, I know that I don't know everything, but I believe there's several kinds of troponin, and it's very difficult to choose between the cutoff and the kind of troponin, the follow-up, and then the changing follow-up of biomarkers.
So thank you very much. Those are two really important questions. And for the first one, you're correct that at the same time we continue to use dextrazoxane in the United States. We use it in South America. We use it in Korea. We use it in other parts of the world. The EMA several years ago, 2011, said based on unpublished studies that were active and ongoing in the United States from the Children's Oncology Group that, gee, there might be a safety signal. And for children, based on that concern, they were no longer allowed to be used in some of the EMA-regulated countries. Interestingly, or sadly, those studies were allowed to continue in the United States. Those studies have now been followed up to reach their primary endpoints. The National Cancer Institute in the United States and the Children's Oncology Group last June at ASCO actually presented as a platform the final results in terms of oncologic efficacy on every single one of those studies in a combined look at this. And that manuscript is in press, I believe, at this time. They found absolutely zero significant reduction in oncologic efficacy. And it's one of these situations where we've sometimes seen this, at least in the States, where for HIV or heart failure, where studies have been stopped prematurely or whatever, or decisions have been made based on that. So that has not been an issue to the point where, put your money where your mouth is, the Children's Oncology Group, which in the United States, more than 60% of all children in the United States newly diagnosed with cancer are treated on protocol. It defines standard of care. When we had more protocols, it was more than 95% of all children. They have just implemented that any protocol that uses an anthracycline at 150 milligram per meter square or more is mandated to use dextrazoxane. It's no longer a randomized question. The National Cancer Institute, Dana-Farber Cancer Institute, Childhood ALL Consortium throughout the United States, Canada, Puerto Rico, since the year 2000, after some of the work we presented was published, said it was unethical not to use it, and they've used it now, and they've published on over 1,000 kids that have been treated without any reduction in oncologic efficacy. It's used on every single child on every one of their protocols. So, and then more recently in August this year, at the same time, EMA has had their decision. The US FDA granted orphan status for dextrazoxane for treatment between 0 and 16 for protection of cardiotoxicity from anthracycline. So it's probably time to readdress it. Now, in terms of your other question, there have been many published recommendations over the last 30 years for cardiac monitoring in children and adults with cancer. Even in the last month, the American Society of Echocardiography came out with consensus recommendations. They didn't use the term guidelines, but in Europe, the organizations have used guidelines. There's many of these. The problem is there's been very, very few studies that you can measure thousands of things during therapy that might reflect the heart. Some of these, like when I showed you the troponin there, we published in JCO 2 years ago that it took about 15 years to say if we measured troponins during therapy, did they in any way predict how a heart was going to be years later after treatment? And in fact, we compared those. The New England Journal in a paper asked us to compare troponins versus ejection fractions during therapy, because in the United States there's recommendations that say you have to do ejection fractions before every dose of an anthracycline. There was no statistically significant relationship between ejection fractions measured during therapy and objective measures of dead and dying heart muscle during therapy, troponins. We didn't have it in the paper. They forced us to put it in the paper that came out in 2004. But then, in 2012, when we published, did any of them predict how a heart was going to be 10, 15 years later? There was no relation between ejection fractions during therapy, and there was a very significant statistical relation between those that had elevations during therapy and late. So then you say, well, does that mean we should be measuring them? Well, the real question then comes up. It's not do they relate. So now we can say that these are biomarkers that have now been validated as surrogate endpoints against a clinical disease state or what your endpoint of interest is. That means that now you can set the stage to do a comparison or a randomized trial of conventional management versus biomarker-guided therapy, with the endpoint not being do you just have a healthier heart, but the balance, as I did with one of my first slides, between oncologic efficacy and toxicity and late effects. Because, yes, we've published in the past that if you followed stopping rules from a lot of cardiology experts that have done guidelines, you would reduce chemotherapy by 20 or 30%. And that's going to, for sure, have an effect on outcome. That does not mean that you're going to, overall, over a lifespan, improve people's quality of life. So these guidelines sometimes take on an unintended consequence. They take on a life of their own until you really do the studies. And there really haven't been the studies to say that short of congestive heart failure, that any of these recommendations really truly tell you, are you doing the right thing for your patient?